For this nursing research class, I've decided to look at coronary artery bypass grafting and transcatheter aortic valve replacement. I chose this because, and you'll commonly hear me call it CABG or TAVR. Those are common abbreviations that we use for both of those procedures and surgical interventions. I chose this because as a new cardiac nurse, I thought they were the same thing, but using different methods. Now, they both help blood flow to be improved with to the heart, but they do it completely differently. The coronary artery bypass or CABG does it by fixing your arteries and veins, and that you bypass the part that's blocked. The transcatheter aortic valve replacement, or the TAVR, does it because we go in through your femoral artery or your transapical artery, and we fix the valve issue. So we kind of just push in a valve, and I will discuss that later on during my literature review part of the presentation of what each procedure is, because it's really important. And I learned through doing this nursing research that they're very different. Now, they both improve blood flow, like I said, but there's some key differences to each procedure. The reason why this is an important research is because as a new cardiac nurse that I wasn't sure on why my patients were receiving what my patients were receiving. I thought that maybe hospital administration was involved. I thought maybe patient satisfaction was involved, because with a patient that's receiving a CABG, it is a mid-sternal incision. It can be quite long, and they also have to crack your ribs. So there's that issue. And then those patients are they're on sternal precautions. So sternal precautions are where they can't lift, push, pull anything greater than 10 pounds. And that includes lifting your body up in bed. And so I thought maybe patients weren't satisfied. Because the TAVR is a pretty minimally invasive procedure compared to the CABG. Now, it's still a surgical intervention, but compared to the CABG, it is minimally invasive. So I thought maybe that is why. Or maybe hospital administration was involved, because the whole goal lately is get your patients out as soon as you can. We have estimated discharge dates as soon as the patient is in the hospital, and let's get the patient out of the hospital as much as we can, because a CABG patient, they're in the ICU between 1 to 3 days, and then they go to intermediate care between 3 to 4 days after that. So they are not discharged from the hospital until 5, 6, 7 days, 5 days being the earliest. A TAVR patient can be discharged the next day. Their latest discharge is usually 3 days, and that is where we potentially see that there was a complication, or they just didn't handle the anesthesia appropriately. But most of the time they're out the next day. So I thought maybe hospital administration could have possibly been involved with that. I was completely wrong, and it was nice in this research to figure out why cardiac thoracic surgeons picked between the CABG and the TAVR. So when I'm thinking about what the problem is, and the statement of problem that we had to come up with in this class is, with the goals of focus in the hospitals throughout the country becoming about budget concerns and patient satisfaction scores and short hospital stay goals, which cardiac surgery is the best procedure? Is it the CABG or is it the TAVR? And this problem affects cardiac thoracic surgeons and nurses, because what are we trying to figure out is the best procedure for our patient? Both procedures improve blood flow. So do you do a TAVR if the patient cannot successfully handle a CABG? And so what this paper has really outlined is that it's not just a numbers game. It is two completely different kinds of procedures, and each patient has to have their own kind of prior to test to see which one is most appropriate for their needs, and what is their structural heart issue. Do they have a valvular issue, or do they have an artery and vein issue? The purpose was to educate the nursing staff and the patients to why they are getting a CABG or a TAVR. And it's not just about numbers, and it's not just the cardiac thoracic surgeon picking, well, I think this is best for you. It is totally and ultimately what their heart needs and what their body can stand. Because the CABG is so invasive, perhaps they are not able to withstand the mid-sternal incision, and so they undergo a TAVR to improve their blood flow and to replace their valves. That can be kind of like a Band-Aid. And so my goal is that after a reader reads my paper or after this presentation, that you will understand what a CABG and a TAVR are, and why a patient may have one or the other. So in my literature review, in the article, What is a TAVR? It explains to us that a TAVR is a transcatheter aortic valve replacement. It is a surgical procedure that is minimally invasive, which will replace the patient's damaged valve. The surgeon will replace the original valve by wedging the replacement valve into the aortic valve place. By doing this, the surgeon now has the artificial valve take over the job of regulating the body's blood flow. So this is the key part. This is where both of them are the same, is that one of them, they're both helping with the blood flow of the heart. So if your problem is blood flow and you cannot successfully, in your body due to other comorbidities, cannot successfully withstand a CABG, this may be a solution. It may or it may not, but this could be a solution, because we are now regulating and producing the body to have better blood flow and the heart to have better blood flow. So this is and a TAVR is usually done for patients that have a lot of other comorbidities, or if patients are elderly, 70s or 80s, which would make sense that they have other comorbidities for the majority of the part. And then in the article, Coronary Artery Bypass Grafting, it defines a coronary artery bypass as a surgical intervention which improves blood flow to the heart. It is a procedure for the heart that has severe coronary heart disease. A CABG procedure is where a healthy artery or vein is harvested from the body and grafted into the blocked coronary artery. With the harvested vein/artery, it will bypass the blocked part of the artery, which improves the blood flow to the heart. So again, it is improving blood flow. So that is the big key part with that I want to educate new cardiac nurses, is that yes, a lot of your patients will have a CABG or a TAVR, and they are completely different procedures, which was not clearly explained to me when I started, but they're both improving your patient's blood flow. So the patient will have less hypoxemia, they'll have better blood flow to their extremities, and overall feel better. And so that's really important. Also, what's really important to note is that when you're taking care of the patient, if it is not an emergent CABG, then they will also have a EKG, an echocardiogram, a cardiac catheterization, coronary artery angiography, and a stress test to figure out if the CABG is the correct procedure, because we want to make sure that all of their other body systems can handle such a tough procedure as getting a mid-sternal incision and a sternotomy, which is, like I said, where we take a saw and we saw through your sternum and pop it open. And so that can be very hard to do. And in that article, it explains in detail what to expect with the traditional CABG, that they will have general anesthesia, that there will be an incision in the sternotomy, that medication will then be given to the heart for the heart to stop, and then they will bypass the grafts, and then medication will be given again to restart the heart, and then chest tubes will be placed to help drain the fluid so that you don't have a tamponade, and then you will be closed up with wires, sutures, and staples. So the article that is noted, I have referenced it in my reference list. It's a very good article to read for new cardiac nurses that clearly explains what a CABG is. So, in the book, Causes and Consequences of Cardiovascular Medicine, it explains what structural heart disease is and what non-coronary heart disease, what the difference between non-coronary heart disease. Structural heart disease can affect the heart valves, great heart vessels, and heart chambers. And this might be where we use a TAVR or a CABG. And so when it is a structural heart disease and you're not able to do an open heart surgery, the only possible intervention may in fact be a TAVR. Now, if we are not able to operate non-invasive, there are non-invasive procedures, but it is better for the patient if we're able to, and if they agree, are able to surgically intervene. So in the hospitals, in a journal, Hospital Variability Length of Stay After Coronary Artery Bypass Surgery, it says we are now doing this, try to fast track. It says majority of patients need less than or equal to 5 days. And then there are a percentage of patients that may need to be discharged in greater than 14 days. However, we are finding that 53% of CABG patients were discharged less than or equal to than 5 days, and 5% require more than 14 days in the hospital. So we have significantly increased how patients can be when they can leave after a CABG. But also noted in an article, new study shows length of hospital stays impact outcome after TAVR procedure. It says that most TAVR procedures are discharged in less than 72 hours, like I explained earlier in the video. So when thinking about what kind of research my research is, I believe it's quantitative research. It's a traditional approach in research in which variables are identified and measured in a reliable or valid way. I found this in my book, Hauser. And when I'm reading about the quantitative research design and why I think that this best fits my research, it's because my research is going to be generalized because it's explaining what a TAVR and CABG are and the different surgical procedures and what is best for a typical patient. Now, it also could be there's also we use this with evidence-based learning and stuff because of the assessment, intervention, evaluation, and outcomes. And this is because we're assessing what's the best procedure for our patient. Then we're intervening with the procedure that our patient's having. And then we're evaluating the outcomes. How did that help our patient? And so that's pretty neat to research and to learn that, yes, this research does actually fit into quantitative research. It also, luckily, fits into qualitative research, which is the natural approach in research. And because we're looking at what is the best intervention when cardiac surgery is needed. And is it a valvular issue or is it or if it's a blocked artery? And so can the patient withstand the open heart surgery? So it's looking at the holistic view for the patient. So the way we're going to sample the patients is that we are going to do we're going to get written consent to look at their chart. Then we'll do an interview. Then we will send out a survey that they'll mail back, and we'll give them an envelope. And then all that information will come back to us, and nurses will keep their identity by having patient A, B, or C. And then we will go through the information and we will input our statistics. And then by using this paper and then able to use my research and seeing how the patient's involved with their procedure, we'll be able to use this for the generalized public, which is neat. So some key definitions, we've gone over a lot of them. The cardiac catheterization is when they insert a catheter up and look at the arteries in your body. The echo is sound waves that produce image of your heart. And then throughout the other parts of the presentation, we looked at it. So I really thank you for listening to this, and I'm so happy that you learned the difference between a cabbage and a tabar, and I hope you did. Hope you have a great day.